Hi, my name is Mohamed Sadek, and I'll be speaking about ambulatory ECG monitoring and Holter reading. This is the talk outline. First, we'll be talking about the history, available devices, diagnostic yield in different conditions, how to approach Holter interpretation, and what's normal, what's abnormal in a Holter, and standard Holter indications in practice, and what to do with abnormal findings. So the Holter was first invented in 1957 by Dr. Norman Holter. At the time, devices were much larger than they are now, as shown in the picture. He donated his invention to medicine, and since then, it's been a vital tool in assessment of arrhythmias and symptom-rhythm correlation. We have multiple devices that are available to our use. We used to have 1 or 2 day Holter monitors available, and if you needed more than that, you would have to get what's called a loop recorder. However, in the recent past, the Ottawa Hospital has obtained 2-week Holter recorders, so now you're able to get a 2-week continuous Holter recorder, which is very useful for infrequent symptoms or if you want longer monitoring for whatever reason. So now you can order 24-hour, 48-hour, 72-hour, or 2-week Holters. There are external loop recorders still available in the community, and you can get those for 2 to 4 weeks, and I'll show some examples of those. And there are also implantable loop recorders, which I'll show as well. One of the things that can happen with Holter recording is if the duration is too short, for example, a 24-hour or 48-hour Holter, you may actually miss the event, especially if the symptoms or the events you're looking for are less frequent than that. So if if you're looking for something that may not appear in 24 to 48 hours, you might want to extend the monitoring period to at least 2 weeks. And this is the standard configuration of a Holter monitor. They come in all different shapes and sizes, and there are some that have 5 stickers only or 3 stickers only. This is a standard one that has 7 stickers. 1 is a ground, and the rest give 3 different leads. And the leads don't correspond to the standard 12-lead ECG leads. However, some of them do approximate the precordial leads. One can also get a 12-lead Holter. These are available especially if someone is looking for a PVC morphology or a VT morphology. These can be useful because they give you all 12 leads. They are cumbersome, however, to put on and wear for extended periods, but they are obtainable if desired. There are event recorders there as well that you could advise the patients to get. So patients who have infrequent palpitations, for example, don't need to wear a Holter all the time. They may simply record the actual event. Now, these are historic event recorders that we don't use very much anymore. At present, most of the time, I advise my patients to buy what's called an Alive Core or Cardia monitor, Kardia. And these monitors or other monitors can be found, and they connect to the iPhone or to any smartphone. And you place your left hand and right hand on it, and it gives you lead 1, which is left hand to right hand, and you get very nice P waves and QRS complexes, and you can identify almost any arrhythmia. These monitors have been great for diagnostics, and the iWatch is similar. And this is the Apple iWatch, and there's other watches out there that can do the same thing, but the actual watch is on the left hand or the right hand, and then the other hand is placed on the knob, and that also serves as lead 1, and it will save a recording that can be shown to the physician or emailed to the physician office later and used to diagnose whatever is happening. Now, the issue with these event monitors, such as the Cardia monitor or the Apple Watch, is that you would have to develop the symptom and then place the device, and these are non-looping recorders. There's also looping recorders out there, such as the wearable loop recorder, where you put two stickers on and you wear it all the time. This is especially useful for syncope, and if there's an event that occurs and the patient presses the button, it records the previous X number of minutes and the next X number of minutes as well. And this could be very useful for syncope when the patient wakes up and then presses the button, whereas an event recorder that only records when you use it will not be useful for that. Now, in the setting of continuous Holter recorders that record for 2 weeks or 4 weeks, this is not as relevant anymore. However, these loop recorders still exist in the community, and you may still be exposed to them. The other technology that we have is an implantable loop recorder. And this is a small loop recorder that could be implanted under the skin. It's the size of a AAA battery. And the implantation technique is quite simple and takes about 10 to 15 minutes. And you will see those on x-rays, and they sit right in front of the cardiac silhouette. And it gives you atrial and ventricular recordings. Now, these are especially useful if there are very infrequent episodes that are not caught on standard Holter recorders. For example, syncope that occurs every 3 months or every 4 months. For such an episode, these devices would be more useful than a standard Holter, and they would give 1 to 2 years of recording capacity. The other good thing about these devices is that they have auto trigger features, in that even if the patient doesn't press the button after they wake up from their episode, the device can record depending on parameters set by the physician. For example, if the heart rate goes less than X or more than X, or there's an irregular heart rate that may signal atrial fibrillation, these devices can automatically record. Otherwise, if the patient presses the button, it will record the previous X minutes and the following X minutes as a normal loop recorder would. So there's multiple ways to record from these devices. There's also some other technology out there, including continuous Holter monitors. These are Holter monitors worn by patients, but with a live agent monitoring at all times. And if there's a worrisome episode, they will call the patient and they will ask them to present to the emergency department. We do not have those available at the Ottawa Hospital, but they do exist out there in the community. And there is also continuous implantable monitors where the patient can see their rhythm at all times. We don't have those in the Ottawa Hospital. However, they also exist. There are, depending on the condition and depending on the monitor, there are different yields. And if it's important to know those, because it may help decide what kind of monitor to order. What about syncope? This is one of the common reasons people order monitoring. And if you look at the literature, the yield of a short-term Holter, for example, 24 to 48 hours, is not that high. And mostly because you may not develop the episode during the time of wearing the Holter. And it's been shown that in patients with infrequent syncope, those who've had negative investigations otherwise, an implantable loop recorder has an excellent diagnostic accuracy in both patients with arrhythmic and non-arrhythmic syncope. And I do have some of the references here for anybody who's interested, but these devices are quite cost effective compared to standard testing, and are actually advised over EP studies or multiple Holter monitors. So if somebody has episode of syncope and have not been caught on standard Holter monitors, it might be advisable to offer them an implantable loop recorder, which will give a much longer monitoring capacity. This is a patient who was actually on the waiting list for an implantable loop recorder because they've had multiple syncopal episodes and 8 previous 24-hour Holters, which have not caught anything because the patient didn't develop syncope during them. But while they were waiting for the implantable loop recorder to be placed, we ordered a 2-week Holter, and during that he developed an episode of pre-syncope with a clear sinus pause, and the patient ended up having a pacemaker instead of the implantable loop recorder. So I do advise most trainees that if you are going to order a monitor for syncope, I would go with a 2-week Holter monitor rather than a 48-hour Holter monitor. You're more likely to catch an arrhythmia. This is another ILR implanted for recurrent syncope that was unwitnessed, and during the episode of syncope, there was significant amount of what looks like heart rate variability on the plot diagram. But when we examine the electrograms, and I'll give you a few seconds to examine it yourselves, there is a background of sinus tachycardia with overlying artifact. So this was actually a seizure episode. Now, although we don't use these devices to diagnose seizures, they could be useful to diagnose non-arrhythmic causes of syncope, as in this case. This patient ended up being referred to neurology and getting the correct treatment, and we removed the ILR after. This is an example of atrial fibrillation with a post-conversion pause, also caught on an implantable loop recorder. So it is quite useful for these kinds of infrequent arrhythmias that may not be caught on standard Holter monitoring. But if you were to order a Holter, I would advise to a more prolonged Holter, such as a 2-week Holter. What about atrial fibrillation? We have some good data to suggest that patients with cryptogenic stroke, the longer you monitor, the more likely you are to catch atrial fibrillation. And in this particular New England Journal paper, they showed that the longer the monitoring period, the higher the yield, and 2-week Holter recorders or 4-week Holter recorders will have a much higher yield than a 24-hour Holter recorder. So if you are ordering for a patient with cryptogenic stroke, you might want to consider a longer monitoring period. For example, a 2-week Holter. This is a example of an old loop monitor that was ordered for to detect atrial fibrillation after a stroke. Now, if you are ordering one of these loop recorders, they have to have the feature of being able to auto-trigger for atrial fibrillation. So if they sense an irregular heart rate, to auto-trigger a recording. Because if it's only symptom triggered, you may miss atrial fibrillation. This isn't as much of a big issue with our continuous 2-week Holter recorders anymore, but if you have access or are involved with these loop recorders in the future, you might want to specify an auto-trigger feature for atrial fibrillation. So with 2 to 4-week Holter recording technology, should we be ordering 24 to 40-hour Holters anymore? And the answer is yes, they do have their place within cardiac practice. And even though we have technology that will monitor for more, if there's no need for them and you're only looking for something that could be caught within 24 to 40 hours, we should use those monitors instead, due to inconvenience for the patients of wearing the Holter recorders for a long time. And some of these indications for shorter-term monitoring include frequent symptoms such as daily palpitations, if you want to assess rate control and atrial fibrillation, if you want to assess the PVC burden, pacemaker troubleshooting, and accessory pathway conduction. These are indications for shorter-term Holter recordings. So how do I approach Holter interpretation? And I'll go through my own personal approach, but there's multiple approaches out there. This is my personal approach to Holter interpretation. I first look at the question asked by the referring physician. What's the indication for the Holter? Are they looking for palpitations, for syncope, for atrial fibrillation? And I always, at the end, try to make sure to answer their question. Always look at the patient data first, at the Holter duration, what medications the patient is on. Have a quick look at the baseline rhythm. Are they in atrial fibrillation and the sinus rhythm? Assess for any atrial arrhythmias, ventricular arrhythmias, and heart rate trends. Then review the diary of the patient. If they have any symptoms, you want to correlate those to any rhythms, whether it's normal or abnormal, and review the tracings. Following that, you can make sure you answer the question of the referring physician. So first, read what is the question that's being asked. Look at the patient data. This is a standard Holter front page that you get with most Holter labs. There are other companies out there that may give a different page, but most Holter companies will give you these standard readings on the initial reports. And the first thing I look at is the patient demographics. And this includes what's the indication for the Holter, what medications is the patient on, and the duration of the Holter recorder. The next thing I look at is what I call the quick look. What's the baseline heart rate data? And it's on the left side here, and it gives you the minimum heart rate, the average heart rate, and the maximum heart rate. One thing I look for the minimum heart rate is what time of day was it? You know, a lot of people will have the slowest heart rate during sleep, and it's clinically irrelevant. So if somebody's heart rate dips to very low or they're having pauses during sleep, you might want to suspect sleep apnea or something else like that, or just sinus bradycardia during sleep that you may not need to clinically act upon. So it's important to know the time of day of the bradycardic episodes. The other thing the Holter will give you on the front page is episodes of AFib. Now these need to be confirmed by looking at the tracings, but it's quite useful to know if the patient's having suspicion of AFib before you start looking at the tracings. The next thing I look at is counts of atrial or ventricular ectopy, and if there's any atrial or ventricular runs. Now we use these reference values. Rare is less than 1 PAC or PVC per hour. Infrequent is 1 to 10 per hour. Frequent is 10 to 100 per hour. Very frequent is more than 100 an hour. And we tend to define those within our conclusion report. Other institutions might use different cutoffs. Um, so it's important to know or define what you're reading or how you're defining the frequency to the person you're sending the interpretation to. The next thing I look at is the heart rate trend, and there's other information given in the Holter report, such as ST segment changes or other counts that you may or may not decide to look at. There's also number trends given during the report that are sometimes useful to look at if you're looking for something specific, but a lot of times we just kind of look at those real quick. The heart rate trends, it's important to know what normal is. In general, most people will have a dip in heart rate during sleeping hours and then a rise during waking hours. And this is what a normal heart rate looks like. And with exercise, you may see a gradual increase and decrease in heart rate. Sudden changes are usually indicative of an arrhythmia that would have to be confirmed by looking at the tracings. After looking at the quick look in the patient data, I always review the patient diary and see if they have any symptoms, and I try to correlate these symptoms to the tracings and figure out, do they respond to arrhythmia or do they not respond to an arrhythmia. And after that, I review the tracings and answer the question. So we'll examine some more strips in the coming slides, but when it comes to answering the question, one thing I want to note is you always want to answer it in plain English and try to make it as simple for the ordering physician as possible. For example, this is a patient who had a Holter done for palpitations. We noted infrequent PACs and a narrow complex tachycardia on the second day, and I tend to specify the time of it at a rate of 200 beats per minute, lasting 1.5 minutes for a total of 351 beats. The SVT started with a PAC and ended with a QRS. So this is quite a useful description, both for the physician ordering the Holter and for the physician potentially doing a procedure on the patient. And when we could correlate it with the diary, and that the rapid heartbeat that the patient recorded corresponded to a narrow complex tachycardia described above. So this is quite useful for the patient and the referring physician. And in the conclusion, sinus rhythm with a symptomatic run of narrow complex tachycardia lasting approximately 1.5 minutes. So this is the kind of conclusion that's useful for the physician. You know, a lot of times, depending on the question, you might want to specify different things. So if the Holter is done to rule out atrial fibrillation in the setting of TIA or stroke, you want to specify whether atrial fibrillation present or there is no atrial fibrillation during the monitoring period. I always say during monitoring period, as we can't really rule out atrial fibrillation with a Holter for 2 weeks or you know, a period of that sort. You would need a longer term monitor to completely rule out atrial fibrillation, but during that monitoring period there was no atrial fibrillation. That might be enough for the referring physician. Or they may consider ordering a longer term monitor in case that the clinical suspicion is high. If they're looking for symptom rhythm correlation, you can either say symptoms correspond to whatever, or that there's no arrhythmias to account for symptoms, or the symptoms correspond to normal sinus rhythm, etc. You may also consider that if the symptoms are not present at all during the study, the patient had no symptoms, another Holter or longer duration study could be ordered. So this is what standard reports that are made by technologists may look like, or that are automatically done by the computer. And I always encourage people to amend the report to make it in more plain English and answer the question of the physician, or else they could be quite confusing and people not know what clinically is relevant. So what's normal and what's abnormal in a Holter? You know, there's been a lot of studies looking at what's normal Holter findings in normal individuals. So this was one that looked at asymptomatic male military aviators with no structural heart disease and assessed their Holter findings. And in this population, most of these individuals had some sort of ectopy. Only 11.9% had no ectopy at all. And most of them corresponded to rare PACs or rare PVCs. Some of them had occasional or frequent PACs or PVCs, and a few had very frequent PACs. Now, in this particular group, none had very frequent PVCs, but we do also know that some people with normal hearts can also have very frequent PVCs, although you would have to further assess if and make sure there is no evidence of structural heart disease in that group. In this particular population, many had atrial pairs and ventricular pairs, and some had non-sustained SVT and non-sustained VT. So it's important to be aware that most people has some sort of ectopic burden. It's unlikely to see a Holter with no ectopy whatsoever. Here's a few examples where we're actually able to catch things on Holter. This is the diary we saw before, where the patient had palpitations, and when you look at the heart rate trend, there's a sudden jump in heart rate, sudden onset, and a sudden offset. And this is interesting because it is during nocturnal hours. So actually, sorry, this is during some of it is during nocturnal hours. So um, it's likely not related to activity. And in this particular case, we see sinus rhythm with initiation of what looks like atrial fibrillation. And in this case, we were able to catch paroxysmal atrial fibrillation on the Holter. This is a Holter done for dizziness or pre-syncope. And when we look at the front screen, we see that there is the Holter detected paroxysmal atrial fibrillation, but again, we'd have to confirm by looking at the tracings. And again, we see a sudden onset and a sudden offset, which is likely related to an arrhythmia. And when we look at the tracings, there is definitely a run of atrial fibrillation. Now, one thing to note that during atrial fibrillation, there might be aberrancy related to long short sequences, where the right bundle might become aberrant, and this is called Ashman's phenomena. And a lot of times there is overestimation of PVC burden in the setting of atrial fibrillation. So that's one thing to watch out for. What are some other Holter indications in your practice? Holters might be ordered for frequent symptoms such as daily palpitations. This patient had, actually, I'll keep going for a second. They might be ordered for rate control in atrial fibrillation, where you only need 24 hours to 48 hours of recording to figure out the patient's rate control if you're looking for AF rate control. The PVC burden, pacemaker troubleshooting, and accessory pathway conduction. This particular patient had had a Holter ordered for heart rate assessment 6 sinus syndrome, and it noted a long ventricular run, 36 beats of a non-sustained VT. Of course, we'd have to confirm this by looking at the tracing, and by looking at the tracing, there is something going on. You know, these are sudden offset and onset episodes that don't look like a normal heart rate trend. And when we look at the actual monitor, and this is during waking hours, we see evidence of sinus node dysfunction with junctional escape beats or ventricular escape beats. And here you have a PVC with a retrograde atrial conduction. And these are being recorded by the Holter as a ventricular run, even though clearly this is not VT, this is a ventricular escape rhythm. So it's always important to assess what's the actual rhythm strips before you call an arrhythmia. So this patient had evidence of sinus node dysfunction, and here there's the sinus node resumes activity, and there's a clear indication for a device, as this patient was likely symptomatic. Here's a example of a pause at 4 a.m. And one of the things, these are usually asymptomatic because the patient's sleeping, and one of the things to look for in these particular cases is sleep disorder breathing or sleep apnea that may lead to such pauses. But in the absence of symptoms, there is no indication for pacing in these cases. This is an example of a patient with lightheadedness, multiple episodes of lightheadedness while wearing the Holter, and all the strips corresponded to normal sinus rhythm at normal heart rates. And this is helpful because at least it rules out arrhythmia as a cause of the patient's symptoms. Other indications might be rate control and atrial fibrillation. This is a patient with what looks like persistent atrial fibrillation on the Holter reading, and in this particular case, the average heart rate is quite well controlled at 59 beats per minute with a normal distribution. And here you see that the minimum heart rate is likely during sleep, which is normal. And it's quite useful to decide on beta blockade or calcium channel blockade aggressiveness. In this particular case, if the patient is on a beta blocker, consideration might be given to lowering the dose, depending on their other conditions. And we already discussed what a normal heart rate trend tends to look like. There's a dip during nighttime and then increase during the daytime. And like I mentioned before, even in patients with atrial fibrillation, you may see these pauses at night that are, of course, asymptomatic. And in these particular cases, there's no indication for pacing. Um, it's normal to have these pauses at night. Always look at the diary and try to establish any symptom rhythm correlation. This patient had significant episodes of palpitations and feeling chest tightness. And you could see that there's something going on with the heart rate trend. There's a sudden onset of some sort of arrhythmia. This does not look like a normal heart rate trend related to activity. And here we see sudden onset of what looks like atrial fibrillation. So this patient had paroxysmal atrial fibrillation. He also developed during waking hours post-conversion pauses that are symptomatic, and then you may want to decide whether you want to treat the atrial fibrillation with rhythm control or address these pauses depending on the clinical scenario. Holters are also useful for PVC burden. There is an entity of PVC-induced cardiomyopathy in patients with more than 10 to 20% PVCs, and in these cases, referral for control of the PVCs and assessment for EF recovery is important. Now, of course, a lot of times PVCs are secondary to structural heart disease rather than the heart disease being secondary to the PVCs. So further workup of these cases is important, but knowing the actual burden of PVCs can also help in these cases. And there is some good data out there showing that when the PVC burden is more than 10%, then PVC-induced cardiomyopathy is more likely. Less than 10%, it's much less likely to develop cardiomyopathy from PVCs. And there's some data showing that there is no normalization of heart function by getting rid of these PVCs. Of course, such cases need a multidisciplinary approach between heart failure and arrhythmia specialists to decide who would benefit from catheter ablation and who wouldn't. Holters can be useful for pacemaker troubleshooting. There are cases of pacemaker-mediated tachycardias where the patient feels palpitations, but the pacemaker itself does not record these as abnormal episodes, as it's normally functioning according to its parameters. However, if the patient is wearing the Holter while the pacemaker develops these tachycardic episodes, then they could be diagnosed. Sometimes in patients with pacemakers, we see examples of what we call pseudo malfunction. For example, here's an example of a non-conducted P wave, and if somebody might see a patient with a pacemaker with a non-conducted P wave, they may assume that the pacemaker is not working. However, this is a particular case of MVP, managed ventricular pacing, which is a Medtronic algorithm, where the pacemaker waits for 2 consecutive blocked P waves before starting to pace. So in this particular case, this is normal functioning of the pacemaker. And here we see that the pacemaker does not presume pacing until there's 2 P waves that don't conduct. And now the pacemaker switches back to a DDD mode. So sometimes there's these subtleties where the pacemaker isn't doing normal things, but it could be misread. So it's important to be aware of these findings. The other thing that you might see with pacemakers is auto-threshold testing. These usually occur at specific times of the day, such as 8 a.m. exactly, which might be a clue that there's a test going on and the pacemaker is testing threshold automatically. The other time Holters are useful is to assess accessory pathway conduction. So this is a patient with pre-excitation, and the big question always becomes, especially in asymptomatic patients, does this pathway put the patient at risk of pre-excited atrial fibrillation and sudden death or not? Now one could order a treadmill test and look for sudden loss of pre-excitation, which is useful. A Holter can also show the same thing. So this particular case, you see that at baseline there is pre-excitation, but with maximal activity there's loss of pre-excitation. Now what I always try to encourage the technologists to do is to print the strip where you see the loss of pre-excitation, because sometimes with activity you see that there is gradual increase in conduction with the AV node, and you slowly lose accessory pathway conduction because more of the depolarization is going through the AV node, and the accessory pathway may still be conducting in the background. So it's more useful to see sudden loss of pre-excitation than a gradual loss of pre-excitation. Now, in this particular case, you see that after a PVC, there is a pause, and the accessory pathway does conduct, but with back to the normal heart rate, there is loss of pathway conduction. So this kind of sudden loss of pre-excitation is useful and tells us that there's intermittent loss of pre-excitation here, and this is likely a low-risk pathway. So Holters can be useful, such as same as treadmills, for assessing accessory pathway. And in a patient who is asymptomatic with a weak accessory pathway, such as this one, they may not want to proceed with an EP study. There's enough information here to suggest that the pathway is unlikely to conduct at rates which would lead to patient death. So what to do with abnormal findings on Holter? And I talk about the SADC scale. This is kind of a joke, but I break them down into very urgent, urgent, non-urgent, or things to ignore. And one of the very urgent things to look at, where you want to bring the patient in and deal with things quickly, for example, admit them for a pacemaker or for some sort of device, is these arrhythmias. So if you have ventricular fibrillation, polymorphic VT, sustained VT, prolonged pauses with syncope, so especially during during waking hours that are symptomatic, I would not do those for nocturnal pauses. Or if there's ST elevation, you might want to call the patient, make sure they're okay, and ask them to come to hospital. This is an example of polymorphic VT initiated by a PVC, where this is quite worrisome, and you may want to bring the patient in to see what's happening, whether there's an electrolyte abnormality or ischemia or long QT, for example. This is another example of a Holter that's quite interesting. It looks like monomorphic VT, and this patient was actually called to come into hospital to assess. But I always encourage fellows and residents to look at the breakout of the arrhythmia, whether it's the initiation or the termination, and trace the QRS complexes back into the arrhythmia to make sure that there's no artifact. So here, if we look at the RR interval after the so-called arrhythmia terminates and we trace it back, we see that there is spikes at exactly these intervals. You could see one here, you could see one here, you could see one here. So this was actually an example of artifact, even though it looks quite scary. And it looks like VT, but if you actually trace the RR interval back, you see spikes exactly where the QRS complexes are supposed to fall. So this is a nice example, probably the best example I have of artifact. And this patient did not need a defibrillator or further workup. This was a normal Holter monitor. This is another example of artifact here. For some reason or another, the QRS complexes are getting smaller and smaller, whether it's the sticker coming off or something else. And then you see this artifact here. And the reason to know it's artifact is if you measure the RR interval and you keep tracing it, you see they're falling at exactly where it's supposed to fall. And when the rhythm terminates, you see that it continues. So whether it's the beginning or the end, trace the RR interval forward or backwards and make sure that you don't see anything during the arrhythmia that will correspond to this. This is actually a referral to the arrhythmia service for consultation. And when we saw this, we called the referring physician to explain, and we didn't need to see the patient. So always watch out for artifact on Holter monitoring. This is an example of intermittent heart block where the patient develops syncope, and you see that here there's P waves without QRSs for a prolonged period. For something like this, during daytime hours, I would call the patient and ask them to present to hospital, and most of these patients are quite symptomatic. This is also an example of paroxysmal heart block where there's a PVC that initiates an episode of heart block, and this was associated with an episode of syncope, and the patient presented to hospital and underwent device insertion. Some arrhythmias are more urgent than emergent and could wait till the next working day. These include complete heart block, if there's a reliable escape, Mobitz 2, alternating bundle branch block, significant symptomatic pauses, non-sustained VT, symptomatic Mobitz 1, SVT with impairment of consciousness, or WPW with atrial fibrillation. And here I would probably call the patient the next morning, the next business day, and ask them to come to hospital for a presentation. Um, this is an example of a 58-year-old woman referred for assessment of syncope. This is her baseline recording showing signs for them. But while wearing the Holter monitor, she developed what looks like an SVT associated with the presyncope. So the next business day, we called her and asked her to come in, and the treatment was established. This is a patient with an episode of non-sustained VT and palpitations, and a lot of times when we see that the VT is positive in all precordial leads, it's likely outflow tract VT. But again, this is not a 12 lead, so I would ask the patient to present to my office, do a 12 lead ECG or a longer 12 lead rhythm strip, try to catch some of these arrhythmias, and assess for structural heart disease. This could be VT in the presence of a normal heart, such as RVOT or LVOT VT, or VT with structural heart disease, which is more worrisome. And this is the same patient who had PVCs initiate SVT. So she had both VT, non-sustained VT, and SVT on the same Holter. There's also non-urgent, where you could see them as in an outpatient clinic a few weeks later. These include SVT or AFib and flutter. A lot of times for the atrial fibrillation, I would send the note to the referring physician to quickly so that they can discuss anticoagulation. But once anticoagulation is established, whether to pursue rhythm or rate control could be done a few weeks later. And this is an example of short atrial runs which could be addressed as an outpatient consultation. Things to ignore or not to are not always clinically relevant or require further attention are PACs or non-sustained atrial runs. These are quite common, like I've mentioned before, and don't always need further testing. If in patients with PVCs, and most of the time these are quite benign and most people have some burden of PVCs, but if they're frequent or very frequent, you might want to consider doing an ultrasound echocardiogram to rule out structural heart disease. This is an example of a patient with PVC and a short atrial run. In this particular, if I see this on Holter monitoring, I will report it in the Holter, but not necessarily alert the referring physician that anything needs to be done. There are some gray areas when it comes to Holter recording. Some of these include what to do with very short runs of atrial fibrillation. So there is some data out there from the ASSERT trial showing that patients with longer subclinical arrhythmias may have a higher risk of stroke. And this data is from pacemaker interrogations where these patients are asymptomatic but being monitored for longer durations with pacemakers. And when they come to the device clinic, you see that they have these atrial runs or runs of atrial fibrillation. And the question is, when are they clinically relevant? And as per our CCS guidelines now in 2020, short episodes of less than 6 minutes warrant watchful waiting. Those with longer than 24 hours, we suggest commencing anticoagulation as per the CCS guidelines. And those lasting longer than 6 minutes but less than 24 hours, there are present studies happening to decide what to do with these patients and randomize them to anticoagulation or no anticoagulation. And hopefully in the future we'll have better understanding of what to do with those. But in those with a very high VAS score, we still don't know what the right answer is, and hopefully future studies will tell us. With respect to the ST segment, there's very little clinical utility in Holters. The right test would be a treadmill or a stress test to decide on whether there's ischemia. There's also, a question of whether it's artifact or related to body positioning. So, and I'll show some data showing that body positioning does actually alter the T wave morphology or the ST segment, and actually having a large meal can also alter the T wave morphology. So, with respect to ST segment elevation, especially if it's accompanied by exercise or chest pain, then I would take that very seriously and contact the patient. But for ST depression or minor ST changes, you might want to order a more useful test like a treadmill. There has been some reports of changes in body position relating to T wave or ST change abnormalities. And just by simply changing the body position, there's pronounced changes in the ST segment and the T wave. So that's why a Holter is not the best tool to assess ST changes. And if there's any worry or concern, I would order a treadmill or a stress test. So in patients with stable CAD, asymptomatic ST depression is common, and if you are suspicious of coronary artery disease, then order the right test. In patients without known CAD, you can consider further testing depending on the clinical scenario. Hopefully that was useful, and please feel free to contact me if you have any further questions specific about Holter reading. Thank you.